Dr. Herrero is going to be talking about options for screening and cervical cancer prevention in developing countries, and he has a lot of experience with this.
Okay. Where is this? I don't see the, it's there, but not. Okay. Experience with that, but not with this.
Yeah, which one choose?
This one. Okay, thank you. Yes, I will try to discuss a few more things in relation to different options for screening and cervical cancer prevention in developing countries. Of course, there's some overlap with all these talks, and we will be discussing similar aspects, maybe with different views. So we know that cervical cancer is still the first or second cancer in most developing countries. That everybody knows that, I suppose, here, and that's why we're here. And you can see that in several areas in Latin America, all of sub-Saharan Africa, Southeast Asia, it's still the first, it's the red, where it's in red there, and particularly for younger women, 15 to 44. Now, we have a lot of recent knowledge of the natural history and biology of HPV and cervical cancer that has resulted in new primary and secondary prevention methods. In particular, of course, the development of the vaccine, and on the other hand, new approaches for screening, new potential tools for screening. We know a lot about the natural history, a very common infection that tends to regress most of the times, but in a few people tends to become persistent and develop, and among those people, precancer develops, and over a long period of time, it can become a cancer, and during all that period, there is an opportunity to detect it with different screening methods, and that's why it is considered preventable, and that's why there has been a lot of success in developed countries for reducing the impact of this disease. We know that this is from Guanacaste. We know that there is a rapid clearance of infections. This is the rate of clearance is the light blue here, and we can see that 68% or almost 70% clears among all the prevalent infections at 12 months, and then among those that persist is where we start seeing the development of lesions. We also know that over time, the most important types are HPV 16 and 18 that have a much higher risk of developing lesions than other oncogenic types, or than negative women, of course. We know a lot about the natural history, and there have been different classifications, etc. Now, the key aspect is not so much the test. We know that we need to have screening programs that ideally should be organized, population-based, including quality control, training, multidisciplinary teams, information system, performance evaluation, etc. But these programs are very rare, really, in developing countries, where you saw José Jerónimo showing all the very difficult conditions in many of these areas. So, but this has to be kept in mind whenever there is an attempt to introduce an intervention in a developing country, that the framework of this activity has to be some kind of program, not an isolated activity, because if it is not really taken up as a permanent activity by the local governments, it is very unlikely to have any impact. Now, in developing countries, we have to know that cost and program complexity are real limitations. That means that we have to accept that as a reality. We cannot expect that to set up a wonderful program that will work like in Britain, because that's impossible. We have to know that. So we have to accept that we need to do what is affordable and what is feasible in these countries. and that our programs will not be perfect. And we have to accept that to use methods that will have reduced sensitivity, and also that they will not be very specific, and there will have to be some degree of over-treatment sometimes. So this is very important. And then there are many aspects in low-resource settings that need to be seen under a different view. For example, the target populations, the tests, the frequency, the way to triage and diagnose, the treatment, the follow-up care, the coverage, etc. For example, you can have different choices for target populations. You can have a broad range, for example, 30 to 64. But according to the limitation of resources, you may decide that you can only do it in a very small group of women, in only a certain age range, for example, age 35 to 39. And then you can decide for a single screen, for example, as the minimum, to give priority to coverage of the majority of women, at least with one screen, is probably much more effective than having very limited coverage, but doing it more frequently. So in a way, the principle should be that first you do one screen on everybody, and then you go ahead and go for the next screen. And so it can take 10 years to cover everyone, and then you do another one. And there is actually evidence that even one-time screening already has an important impact, as long as it is followed with proper treatment, because that is also essential. It doesn't mean screening is nothing if there is no proper follow-up and treatment. That's the critical component, is that if you detect something, you have to do something to diagnose and treat or treat. For triage, there are different options. No, you can do treatment immediately, and we will see this in more detail in a minute. You can treat immediately depending on the method you use. You can try to do, for example, when you do screen and treat with visual inspection, that is like the most the minimal activity that requires the minimum infrastructure. You can triage with colposcopy and biopsies and treat based on colposcopic assessment, but that is the most difficult and complex procedure. So there are other alternatives that we will see. Treatment, we should try to explore and use treatments with cryotherapy or cold coagulation. It may be very hard to implement other type of procedures in very difficult countries, like a lip or cold knife. It's virtually impossible in many places. So in terms of follow-up, you can opt not to follow up after you treat. That's like in the worst case scenario. You can just treat and then go for the next group of women because there is no resources, or at least do a single follow-up at 1 year or 2 follow-ups 1 year apart. Then you can choose different screening tests. Pap Smear, we know that Pap Smear has a lot of limitations, especially in these countries where we have very limited resources. Hpv testing is very promising, as we know. We have VIA and VILI, and this can be done in parallel or sequentially. In terms of cytology, they have worked in developing countries, but the role needs to be reformulated, especially in developing countries. We know that they have very limited sensitivity, as has been shown in this analysis in developed countries, about 50% combined sensitivity. And you saw what happens in Latin America, which is not so desperately developing. So the use of Hpv test can be done together with cytology, as is being done now in the US, and that's they have extended the interval. There is a new guideline that allows extension of the intervals with co-testing that was discussed in the previous session. There is the possibility of doing cytology and then triage with Hpv test for borderline abnormalities. That has been done in the US for a while. And then the new options that are maybe possible in developing countries is Hpv screening with triage by cytology or VIA. If you restrict the cytology to the Hpv positives, There is the possibility that the cytology may be more accurate, may perform better. If not possible, maybe you can triage with VIA and then follow your positives with, at a certain interval. These things are still there is a lot of research in this area that needs to be conducted to define the proper methods to manage the women who are negative in colposcopy or negative in VIA. And then, of course, eventually there will be different biomarkers, ideally, that could be applied on the same or on the same screening samples that can give us a more specific diagnosis. And then it can be used as a test of cure. Self-collection is another very, very promising addition of HPV testing because it has a comparable sensitivity. And it has a very high acceptance in many, for example, studies in Latin America, and I think you have done it in Asia, and it is very highly accepted, and it can overcome barriers not only from the women, but also limitations of the health system in terms of staff and things like that. So it's another very big advantage of HPV testing. HPV testing, of course, we know is more sensitive to detect precursor lesions. Should be restricted to women over 30 because before that, the prevalence is very high. And then the high negative predictive value allows extension of the interval, maybe for 5 or 10 years, which is another big advantage of HPV testing. We know that it is very high in young women, so we should try to go for women after they turn 30, where the prevalence goes down to 10%. This may not be the case in some areas, and some studies in Africa have shown different curves that also have implications for these kind of approaches, but and that needs to be defined for the specific country. Let me just move a little faster. The use of HPV as a single intervention has already been shown in India, for example, to reduce mortality from cervical cancer. In India, in the study published in 2009, they randomized clusters to HPV testing, cytology, visual inspection, and there was a control group, and they followed for cancer incidence and mortality. And they demonstrated a reduction of about 50% for stage 2 plus cervical cancer incidence, and about a similar reduction in cervical cancer mortality. That shows that even, and there is new data that this reduction remains very high. And this demonstrated in that same study the very high negative predictive value. This is the cancer incidence rates among screen negative women by study group. There was very few in the HPV negative women, very few, very small incidence rate compared to either cytology or visual inspection. There is also in the Cape Town study, is very important, of screen and treat, where they randomized about 6,000 women to screening and treating immediately HPV positive women or VIA positive women, and then another group had just delayed evaluation. And you can see that the cumulative, and then they followed up for 36 months, and they found the cumulative frequency was much lower in the women who had HPV screen and treat compared to for the delayed evaluation, with a protective effect of almost 70% in the HPV group. Now, José discussed the new CARE HPV, and you will hear a lot about CARE HPV, I think, during this meeting, because it was recently approved by the Chinese FDA, and this is supposed to be going into the market, and we should learn the conditions and the plans of the company for introduction of CARE HPV. It has a lot of very good reproducibility, and it was, as it was shown in the Chinese studies, a very high sensitivity Also high, but a bit lower when it's done in vaginal specimens. So as we said, HPV, I'm running out of time. HPV has a lot of advantages that we discussed, has some disadvantages, limited specificity in some areas, especially high cost, but that may be going in the right direction now with a reduction in price. There is problems that there are too many positives, and we need to define how to follow them. There's some technical requirements, and the fact that knowing that HPV is there, it represents potentially a social stigma that needs to be investigated and needs to be addressed as well. So then the visual inspection, I think Jose already discussed it, and it has immediate results, needs no equipment or limited qualifications, simple training, very cheap, and reduces the number of visitors, but has limited sensitivity and specificity, and there may be a lot of over-treatment potentially. But in another study, it also showed a reduction in cervical cancer incidence and deaths in another study in India, although it didn't show it in the other study. So in summary, since my time is off, we should say that we should have to vaccinate girls as much as possible, and there is the Gavi initiative that is providing vaccine at very low cost for the eligible countries. Prices are negotiated in Latin America, for example, and that has brought the price down to about $14, and there is already, Nubia, I'm sure, will present the progress of vaccination in Latin America. I think there is still a lot of work to do in many other areas, and also development of new vaccines that may turn out to be less expensive, production in other places, more competition. And I think I'll finish there. Thank you.